Good afternoon, everyone. This is Sandra Stable, Improvement Facilitator at the Edmonton Southside PCN. I'm at the Edmonton West PCN today with all of our colleagues in the Edmonton zone. So I'll just be kind of facilitating the call, but we'll have a bunch of other speakers on the call today. So we can move to the next slide. All right. As Leanne just stated, if you have any questions, comments throughout the call today, please use the chat function. It's on the far right side of your screen, and make sure that you're chatting to all participants. That way everyone can see the questions that are posed. Next slide. So let's practice. So why don't we just put your name and where you're calling from. So either which PCN or which clinic. Let's just take a couple seconds here to just check where everyone is calling from. Track along the side there, we have Wood Buffalo and St. Paul and Sylvan Family and Rocky Mountain House. Week working in Edmonton, some folks in the AMA office, from a little bit all over the province, which is our goal, considering this is a provincial F network. So kind of neat to see where everyone's calling from. All right. You can just keep checking in if you'd like along the side, and everyone can follow along. But let's move along to the next slide. Just a reminder that this call is this webinar. This is our 5th webinar. We started this just this past October 2017. And the point of this group is to try to share experiences and collaborate provincially. So everything that is shared in this call is meant to be kind of interpreted within the lens of your own PCN. We're just here to share and learn from each other. Next slide. So, like I said, welcome back. 5th webinar. We'll be hosting a webinar in April, another one in May, another one in June before taking a break for the summer. So you can expect 3 more webinars. We'll talk about that a little bit at the end of the call. But our focus for today will be on the HQCA physician panel reports. And we're going to take a bit of a different angle. Sue will be talking us through what elements of this HQCA report are most valuable as an IF. And then we'll hear about some stories from a couple different groups that are using the HQCA reports within their clinics. So we have Laura that will talk about a specific clinic example, and Amanda and Peter that will be talking about the Mosaic PCN's example. And we'll finish off kind of with a teaser for April. So next, please. I'll pass the torch along here to Sue Peters. Sue Peters is an improvement advisor with the AMA, with TOP, out of the Edmonton area. She works mostly the north side, or the north Alberta. Yeah. Yeah. And so, Stu, I'll pass it over to you, and you can do the lead for the rest of the call.
Perfect. Thanks so much, Sandra. Well, welcome everyone to our webinar today. I'm so pleased that you're all able to join us. I'm actually going to stop sharing my screen at the moment because we're going to try, you're part of a PDSA today, and we're going to revisit polling and see if we can get some polling questions to work in WebEx today. And so I'm going to rely on Leanne to help me out with this polling because it's a little too complex for one person to do by themselves. So we're going to start with our first poll, so get ready to answer. So you should see the poll coming up, Leanne.
Yeah, so our first question today is, have you seen an actual HQCA physician panel report? On your voice and click submit, that would be great. Thank you.
clarity, are we talking about last year's reports or this year's reports?
Either one.
Thank you.
Susie, on my end, it says the poll has ended, so I don't know if people are able to select answers or not.
Share them. So you should be able to see the results now.
Not yet. I think there's typically a little bit of a lag here before the results come up.
Move on to the next one. I think, let's see, let's try this one. Open poll.
So who has an opportunity to review an HQCA physician panel report with the physician? Yes or no? The poll has ended. The results will take a little bit to come up, so I'm not sure if you had another poll you wanted to do or go back to the presentation.
Oh, that's interesting. I agree. This could say apply. Okay, let's try another one.
Okay, how do you usually get the reports? And there are choices there. Select from and submit.
So we're getting a mixed bag of results. Let's see here. Responses. Sorry, I apologize. The WebEx polling is it's so delayed in the responses. Okay. You know what? We're going to move on to the presentation now. So back to sharing my screen. Now, before we had talked about presenting this information, we were encouraging people to attend one of the HQCA webinars with Jody Powell. And if you had a chance to view that webinar, it's a really good overview of the report, and Jody presents much more detailed information and a little bit different lens than what we're looking at today. If you haven't had a chance to review one of these webinars, here are the dates for the ones that are still upcoming, and we will be happy to send these out to you through an email from the IF network. So we'll be happy to share that. So when we're talking about panel reports, of course there are lots of many different panel reports. The ones that we're probably most familiar are with panel reports that come from our electronic medical record. And another type of panel report is that available through the for the Health Quality Council of Alberta. And what is really interesting about those reports is that there is information from external sources that don't exist within the EMR. So it does provide you with different lens. We're really encouraging physicians and their teams to use the information that is available from the HQCA reports to strengthen patients' medical home by improving panel management, continuity, access, and quality of care for their patients. And HQCA has made a commitment that they will make these reports available to all physicians in Alberta. They have really scaled up our capacity over the last couple of years, and so have made a commitment that any physician or provider who would like a report will have access to it. So we're very interested in, as an integrated team with our partners at the AMA, is how do we leverage you as improvement facilitators to make this happen? And so that's part of why we're sharing today. The approach that I thought I would take is in a series of tips around the HQCA report. And so the first tip is consider the type of report to recommend to your physicians. There are a number of different reports that are available. So there's the Physician Proxy Panel Report, the Physician Confirmed Panel Report, and I'll talk more about those in just a moment. But there's also a clinic report that is available. And so if you're from a clinic, you can actually order a report on behalf of your clinic. And HQCA is able to accommodate up to 20 participating physicians for each clinic report. And then, of course, there's also the PCN report. So each of your PCNs have just received a report from HQCA that reports on the same information that's provided in the physician-level report for the PCN panel. And so I've used this report, the PCN report, to engage physicians and boards at PCNs and actually use their PCN data to go through the report with my goal of them learning more about their panel at the PCN, but then also getting them interested in what's available with the physician-level reports. In terms of the physician-level reports, there are two options available. One of them is the Physician Proxy Panel Report. And this is for a panel that may not be entirely squeaky clean yet. And so there's an algorithm that used to be a 6-cut that has now been revised this year to a 5-cut method. And so basically it goes through an algorithm and it assigns a physician a panel of patients. Another type of report is called a physician-confirmed panel report. And you'll notice that some of the terminology is changing as we are getting ready for the St. Cyril Patient Attachment Registry. We're being very clear on what's confirmed and what is verified. So we're calling this report a confirmed patient panel. And so this is an option, and what HQCA will do when a physician requests this report is provide directions or instructions back to the requester on how to upload a file that will allow HQCA to run the report on a specific group of patients. This is how a physician would request or someone as their designate the report. And you'll notice that here is where it talks about the type of report. And here you're able to select whether you want a proxy panel report or a confirmed panel list. It's possible to order both as well, and there may be some interesting cases where that would be provide some really interesting information. So another tip that I have is know about the timing of the reports. And this took me a long time to figure out. I was really confused about when reports were available and when they were not. So this current report data set goes from April 1st, 2015 2014 to March 31st, 2017. And these reports will be available until probably around November of this year. And what happens in November is that HQCA obtains access, along with Alberta Health and Alberta Health Services, to the next year of data. And when that happens is they stop issuing reports, physician panel reports, and they start building the reports for the new data set. And it's a very manual process. It takes them a couple of months to rebuild all the reports based on the new data set. And so during that time, they will keep track of physicians who request the reports, and then once they become available, likely in February of the next year, then they will start issuing those reports. Just a comment about this year. The timing of the reports has been a little bit delayed, so they started delaying the proxy panel reports to physicians, and there was a data issue that was identified by several of the physicians, and so they stopped issuing the reports, and they're currently going back to reissue those reports, those proxy panel reports. And this has delayed the release of the confirmed panel lists by a few weeks. So just wanted you to be aware of that. Now, where does the data come from? And this is not, you don't really need to know this, but you just need to be aware that this data is coming from a number of different sources, including the Physicians Claims Database, Alberta Health Pharmacy Information Network, emergency department visits, inpatient data, number of data sources. So this is all information that is not necessarily accessible in the EMR, and that's where it provides so much value along with the panel reports that you can get from the EMR. Tip number 3 is use the electronic version whenever possible. HQCA has done an amazing job over this past year in terms of making the report much more friendly to use. And so there is some great report navigation built into the report. So if you're looking at this summary document, you basically can click on the page number and it will take you to that page number. And then once you're done looking at this data, you can then click at the top where it says Return to Report Overview, and it will take you back to the summary page that you were looking at. So it's much more easy to maneuver around the reports. My tip is leverage the comparative data. So this is showing diabetes screening results for the physician panel report. And see here where the physician's panel data is presented in comparison to the PCN and also to the zone. Physicians are very, very interested to see how they compare to others. And so consider the comparison to be an engagement strategy for you. Now, just to show you the difference between the physician panel report, here is an example of the same screen or diabetes screening indicator for the PCN panel report. You'll notice that in this comparison, the PCN panel is compared to the zone panel, which is also then compared to the Alberta panel. And that's basically the main difference between the physician level report to the PCN level report. They're almost identical. And that's why using that PCN data is a great way to get physicians and teams comfortable with the information. It's just who you're compared to. It just changes a little bit between those two reports. The next tip I have is start with the report overview. This year, HQCA has built in a beautiful summary page, and this is on page 3 and 4 of the new report, and it's a great overview of the data in the report. You can see here that it includes really nice information about the panel characteristics. Here is information on preventative care and imaging. Also included is information about chronic conditions, and again, it's very maneuverable. You can click on the chronic conditions, page 30 to 36, and it will take you right to it. It also provides information about pharmaceutical usage, and there's much more information than what is just shown here in the summary on those pages. It also talks about utilization. So this is family physician visits for the panel, ED visits, lots of great information in there, and we'll look at a few of those in a moment. Tip is look for the arrows indicating top areas of success and top areas of opportunity. When we were looking at the summary, you might have noticed these arrows. So these green arrows pointing up mean that the physician's results are in the top 16% of physicians in the zone. And there aren't any in this sample report. Again, we will send you this sample report out and make those available on the Collaborate page, this summary sample report. So if you see the arrow pointing down, the yellow, that is indicating that the results for this physician are in the bottom 16% of physicians in the zone. Now, to click on that area that is showing they're in the top 16%, again, you'll see the green arrow being depicted here, as well here saying your result is in the top 16% of physicians in the zone. So it's really very handy, quick way to look at overall results. Tip is check out the interpretation and tips provided for each measure. HQCA has done a great job talking about the measure, so providing more information to the reader of the report. It also provides an interpretation and then possible actions. So there's links to toward optimized practice, to access improvement measures, some great suggestions on what a physician and team might want to do to consider improving an area that has been identified on the report. The next tip is engage physicians around continuing medical education opportunities. And so there are a number of CME credits, both certified and non-certified activities that are available. And we will also make available a two-pager summary of the CME activities that are available for physicians getting their report and linking learning to practice and answering some questions about the report as they're going through it, say with an improvement advisor or improvement facilitator to support that learning. So there's a number of credits that are available. My tip is focus on the physicians with or what's in it for me. And I thought that it might be helpful. We certainly don't have time to go through every aspect of the report, but I wanted to focus on a few areas today that might help tap into some of those physicians with them. So let's talk about continuity. So we're going to be hearing a lot about continuity over the next year, and we know that continuity is essential to improve patient care and achieve healthcare system transformation. So you'll be hearing a lot about continuity. And of course, the Central Patient Attachment Registry, or CPAR, is a technical enabler to help improve continuity. The HQCA report is a great resource to tell a physician about their current continuity. In the report, on page 6, you'll find this graph, which basically breaks down the physician's panel into high, medium, and low continuity. So high would be considered if that 80% of the visits were to this physician. Medium is 50 to 80% of the visits were to the physician, and low continuity means that less than 50% of all visits were to the physician. The report also breaks down the percentages and compares it to your panel, to the PCN panel, and the zone panel. And this information is provided for the last year of data in the time frame. And so when you're working with your physicians and talking about continuity, what categories do your patients fall into? And if you have patients that are falling more in the high and medium continuity categories, it would suggest that a physician has a stable practice, that patients have good access to that physician, and that physician is seeing few patients of other physicians. If patients fall into more of that low continuity category, it could be because a physician was building a practice over the time frame that the report was available. Often perhaps saw patients of other physicians, so it could be a physician that's providing urgent care, walk-in or after-hours care, or it could be a physician where there is an access issue and patients are having difficulty trying to get in to see the physician. Also included in the report is the average physician continuity over time. And so you can see this physician continuity seems to be increasing over the 3 years of the report. Next thing to talk about, let me just go back here. Oh, so this average physician continuity over time, and this is average clinic continuity over time. And so this one, it would be looking at continuity to the medical home. So it looks at a business arrangement and looks at, so if not seeing you, are you seeing one of the physicians that are within your clinic? And so this is helpful as well. Usually you'll see that the continuity to the business arrangement is higher than the continuity to the individual physician. Area that I find physicians really interested in is the burden of illness. And this is currently being looked at by looking at clinical risk grouper. This is going to be changing likely. This year they're going to be changing to another indicator of burden of illness, but right now we're using clinical risk grouper. And this is really how sick are my patients. And so a CRG of 1 is not sick, so it's someone who's healthy. And a CRG of 9 means that that patient is very sick and death is imminent. So this is showing a summary, the distribution of the panel by burden of illness. And so you can see the percentage of each of the categories for this physician. And of course, remembering a higher CRG is those sicker patients, and provides a really nice summary here of the average CRG. So this result of 3.8 means that this physician's panel is sicker than the PCN as well as the zonal panel. And then it also gives an indication of patients with a CRG of 5 or more, and these we tend to think of our patients with complex health needs. And so that is also a good indicator of what type of patients are on a physician's panel. And often we see that physicians their panel tends to age with them, and so you'll see older physicians who tend to have a sicker panel of patients because their panel has kind of grown up with them. So again, just when we're talking about patients with a CRG of 5 to 7, are patients with chronic conditions who are often the focus of chronic disease management. They typically take more resources and visits with team members. They often use more urgent and emergency department care and have more visits to specialists, and are best managed using a patient-centered multidisciplinary approach, such as patients collaborating with teams or PACT. So emergency department visits. So this is really interesting, this one, that looks at when patients are accessing the emergency department. And so this is the physician's panel. And what you notice is that the majority of times when patients are visiting the ED is during the day. And these are for GP-sensitive conditions, which means that these are things that would typically be able to be managed in a physician's office. And so most likely when we see this it's often an access issue that may be contributing to a profile that looks like this. Way that the HQCA report looks at the results is through CTAS, which is the Canadian Triage and Acuity Scale. So again, this is how patients are graded when they enter the emergency department, and one is who are requiring resuscitation, and CTAS 4 and 5 are items or patients that are typically could be seen in a family physician's office. And this is looking at the average ED visits per patient by time of day. So this is really interesting information for the physicians, and they're often fascinated by this. Just a couple of more slides that I have before we move on. Just doing a time check. I think we're good. So another part of the report is looking at complex care planning, and this is on page 33 of the report. This provides information on the number of patients that would be eligible for complex care planning, and then the number of patients that actually were billed for that were had a billing for that in the past year. And so you can see that this physician, none of the patients who were eligible actually received or had a CCP billed for. And this is something that physicians are often surprised with the results. Typically, I've seen them around 20% or so, and this is often an eye-opening data set that they're quite interested in. And of course, we're looking at these patients thinking that these are patients that would really benefit from that complex care planning visit. Last thing that I just wanted to speak to very, very quickly is around access and return visit rate. Now, this report, the return visit rate has come back into the report. It was not available in the report last year. And I just want to throw some caution about the return visit rate. Now, if you are looking on page 8 and actually looking for the thing that is called return visit rate, this is showing the return visit rate for the physician. So it's this panel of patients and how many times the patients have come back to see this physician. And so if you're using this number to inform demand, then probably a better number would be this number, which is the physician visits. And this looks at this panel of patients and how many times the panel of patients were visiting any family doctor, not just the one that they were paneled to. And so if you are looking for information to be plugging into one of the AIM formulas to help you calculate demand, then this is the number you would look at. And I would encourage you to check in with your AIM team for more information about it. I just wanted to flag it as something to consider. And so I know that we are probably quite tight for time right now, and I want to make sure we get on to our other guests. So maybe we could hold off any questions for me until later. So.
Chat in the questions if you have a burning question, so you don't forget it, and we'll try to make sure we have a bit of time at the end to address any questions. We'll have some time after the speakers too, so try to make sure that we address that. So thank you so much, Sue. That's very helpful, and for those of you, if you were kind of quickly trying to write down notes, these slides and the recorded webinar, we'll post it to the Collaborate page after this afternoon, so you can access it there. Next speaker is Laura Dusty. She is on the Provincial Network co-design team, so she's involved in kind of putting together these webinars. And she's an improvement facilitator at the Sylvan Family Health Center, which is a province when it comes to the patient-centered medical home. So Laura, I'll pass the torch here.
Thanks very much, Sandra, for introducing me. So I'm an improvement facilitator in my clinic, Sylvan Family Health Center, and our physicians have decided as a group that it is the improvement facilitator's responsibility to order the reports on behalf of the physicians. So order the proxy panel, the confirm panel, and plans to order the clinic report, which we haven't done yet. And our confirm panel, unfortunately, is delayed, so I don't have a lot of information to share with you on that. But the proxy panel I've ordered, and it usually is quite a quick turnaround. So when you're ordering the panel, if you order on behalf of your physicians, you just have to remember that you will also need their PRAC ID that's required on the website. So I order the reports. They come to me via email. And then what I do is I share a copy of each physician's report to them. And I typically email it to them, and I give them a little bit of time to kind of take a look at that and review that. And then I typically set up an appointment with each individual physician. And what we do is we kind of just sit down and go through the report together, and it gives them an opportunity to, some of the different priorities that are important for for them. So if you can move. The reason why that we say that this is an important piece of quality improvement for our clinic is that it gives us an opportunity to kind of take a glance at some information that we can't necessarily easily pull from our EMR. It's also really nice to see where we fit in as a clinic compared to the PCN and our zone. I've gone through a report with a physician. We kind of pinpoint some of the areas that the physician is a little bit more interested to dig deeper and find out more. And then there's some topics that we use to take back to our quality improvement team. And then, if there's different areas that we're lacking or that we need to dig a little bit deeper, then as a QI team, we can create the PDSAs to make those improvements. We also use some of the data, some of the individual physicians. For example, the diabetes screening section. We will take those results and meet with our diabetes nurse in our clinic from the PCN and kind of work together as a team to look at some of those opportunities for improvement. These are just some examples that we do a little bit deeper dig in our clinic. So if your clinic is already capturing some of the ASAP data through the Alberta Screening and Prevention, this report here on pages 18 to 29, also you can use data to compare where you're at, or if they compare to some of the numbers that you're getting through your screening nurse. Or if you're not participating in the ASAP screening, you can use this information to move forward. And so what we do is we kind of take a look at these and see where we compare to the PCN, and if there is any areas that are quite low in, and then we can take that opportunity to work with our individual groups of nurses and doctors to increase our screening maneuvers and that we provide to our patients. The next section that we're really are important to our physicians is continuity. So we know that continuity is very important for patients' care, and this is just kind of some sample data. And so if your continuity is high, typically, as Sue alluded to, your patients are often seen by their family physician. And if they're low, that definitely gives you an opportunity to either provide some education to your patients about what continuity means and how it's best for their health, and it also can give you an opportunity to review what your access is looking like and your next available needs to be reviewed. And moving through here, just as we are short for time, the other important piece is the adjusted staff physician and emergency department visits. Our physicians are always interested to know how many of our patients are going elsewhere for care, and this just gives us an opportunity to look at our third next available. If our access is not so great, we can look at some contingency planning, backlog reduction. So we take this back to our GLI team and look at different areas for PDSAs to improve. Quick snapshot is kind of what we do in our clinic. So I'm not sure if we want to save questions to the very end, or if I have some of those now.
What, Laura? Let's just move on. That way all the speakers get a chance to say their piece, and hopefully again we'll have a good 5-10 minutes to answer questions.
Great. Thank you.
Thanks so much, Laura. That was really helpful. Our next two speakers are Amanda Brockman and Peter Rimkowitz. They both work at the Mosaic PCN in Calgary. Amanda is a primary manager, and Peter is the director of measurement and evaluation. And they're going to share views on the HQCA report. Go ahead.
Right, Sandra. So we, about a year ago now, took a much more high-level approach to kind of, knowledge or bring it forward to as many physicians as we could as possible. And it was in part development. We called our data to decision CME and worked and identified need to support physicians in using their data to help them make decisions and ultimately support the implementation of the medical home. So you can go to the slide. So CMEs that were of this scale were done actually in like about 2014, 2015 around our paneling, and really the initiation of our panel management program, our primary care coordinator program. And this was meant to address the next steps in the evolution of that patient's medical home, with a strong emphasis on using what we considered to be the top quality of data to support the next steps. So hoped that we'd be able to support physicians navigating data resources, especially data that is specific to that physician, therefore more meaningful, to support clinical service delivery decisions. And we did, or as part of the CME, we did support physicians in getting their HQCA reports prior to the event, so they could sign either through our data sharing agreement or there was links on how they could order it themselves, just so that it was available for them to use during the CME. But we only viewed the reports if they okayed us to do so through the data sharing agreement. Where physicians, we didn't stop physicians who might not have a big enough power or new enough panel to actually receive their own report from coming. So we did support them with providing a sample report for them, just to still work through the process for when they did receive their own reports. And we just stressed that the goal of the CME was around quality improvement at the individual physician level, but also at the system level, in part through the sharing of patient outcomes related to our PCN. And in the development of this, I mean, Peter really leveraged a lot of relationships across the zone, including with Alberta Screening and Prevention, HQCA, and the Physician Learning Program, as well as within our own physicians to help facilitate today. And so Peter will discuss our agenda and format if you go to the next slide.
Thanks for that. I'll build on some of the comments that Sue made. I think it's important for people to understand that data decisions as a CME didn't exist, but was created in response to the evaluation of the PCC program, so the Patient Care Coordinator program. We revamped the structure of the program in 2015 and started to collect patient-level data at that point, and were able to perform an evaluation which showed a significant improvement in screening completions. And so Sue's comment around strengthening the medical home, what we wanted to do is we wanted to create a win-win across systems. So we want to use the evidence that we were able to produce in the evaluation of our program. So we worked with Calgary Lab Services with Dr. Chris Nogler, and we were able to measure on a patient-specific level using approximately 10,000 offers of screen and look at completions within the Calgary Lab Service data. And the goal was to be able to engage our physicians and be able to support our program to continue its expansion. So in the first year of the program, we had 46,000 offers of screen, and our goal was to grow the program. So as we were designing the agenda, what we wanted to do is we wanted to do a high-level context of Alberta cancer screening programs. So Dr. Hoymin Yang came and presented on national and provincial level screening trends, and a real strong message around the fact that screening rates were on a decline. So Dr. presented the trending data, and after he presented the trending data on colorectal mammography and PAP screening, transitioned the conversation from a population health perspective, Marcus Lahtinen and Dr. Oliver David, to look at the Health Quality Council data and to bring some of the content that was presented at a population health level down to the physician panel level. So Marcus presented the report. These were last year's reports. After that, what we thought would go real is if Dr. David would present his actual findings of his panel report, so it would help to reduce some of that anxiety around sharing of data, open up the conversation for physicians to start to engage. One presented the data by Health Quality Council and Dr. David. There was a focus and a transition to now speaking specifically about PAP screening rates. So what we wanted to do is we wanted to have a peer co-facilitated session by the Physician Learning Program. The goal of that session was to talk about screening, both appropriate, where we want to both the appropriate screening as well as discontinue inappropriate screenings. And Dr. Tina Nicholson from the Physician Learning Program, Dr. Sanjay Wadera, and Dr. Ann Dara presented that component of the co-facilitated session, and each time physicians broke out into their table groups to talk about how they could improve screening, as well as how they could reduce or decrease the inappropriate screens that were being offered to patients. Now, this is where the next step in terms of presenting the evidence around our programs. So the goal for us as a PCN was to create a win-win for everybody involved and to focus on quality improvement and patient outcomes. So at the end of the physician-led PLP session, I wanted to present to physicians the fact that we actually had outcomes and evidence around one of our programs that could help them to do the very thing that they were just talking about in their peer-led sessions. So the PCC program, or the Patient Care Coordinator program, they had very strong evidence around screening completion rates as a result of offers of screen within the program and other work that was being done within the clinic. At that point, we presented the outcomes of that program in order to be able to support and tell physicians that there was additional resources that they had at their disposal and that the PCN was there to help support them through their journey in adopting the medical home. So then, this year we will have, the annualized figure, we will have 306,000 offers of screen that we will have recorded. And as an organization, the program continues to expand. And we will be just under 500,000 offers of screen, which we've been able to offer through the program, through clinics that have adopted it. So we continue to do that work and positioning ourselves for future CMEs, focusing on team-based care and continuity improvements resulting from team-based care. We're going to look at access, paneling, again, repeat the screening CMEs which we offered in the last fiscal year. At this point, that's the agenda and the format and kind of the origin of that. I'm going to turn it back over to Amanda to continue.
Great, next please. Oops. So just in terms of logistics for the day, so we did encourage all our physicians across our PCN to attend. Sorry, back one. We did keep it specific to those that were participating in our PCC program or those that weren't. We just kind of wanted to see kind of what we get. And we were 2 sessions, about 50 physicians per each where the capacity was in the session. And so they were completely full. It was well attended. Actually, I think we were a little bit over capacity in both sessions with just physicians that had extra. So it was really great. And so the event went over 4 hours. So a half-day session, we offered one in the morning and then one, I think, a week or 2 later in the afternoon. And then we provided breakfast or lunch, depending on what time of day it was. So in terms of logistics, that went really well. So next slide. Some key factors to success for these events, like just building off of what Peter had said, was that we prepared the HQCA reports and had them available. So we handed them out as physicians checked in. We leveraged a lot of great relationships with other stakeholders that could share their perspectives, and then also, of course, bringing it down to physicians, using physicians and peers to kind of share that. We also keep the information digestible by, again, keeping it specific to that cancer, that PAP screening. And then we used physician champions. We had educational and breakout time for discussion, just so it wasn't a complete session of somebody talking to them, that they actually had some interaction and had the ability to ask questions and have, really meant something to them. And we had lots of support from our PCN leadership, as I think you can see. Next slide. So again, the outcomes of our decisions that we had many physicians sign up to participate in our PCN support program, the PCC program afterwards, and then also others that had really wanted to engage again in even the multidisciplinary team, like having nurses support the work and so forth and on. Really strengthened the understanding of the HQCA report with physicians and how it can be used. Physicians gained insight into their practice and to learn more about cancer screening rates for the PCN and the goals for the province. As Peter said, we're looking at expanding that into additional sessions in a more, way, and so we're really excited to see kind of where that takes us. brings us to the end. Sandra?
Thanks so much. That was awesome. We posted a lot of workshops at the Southside PN in Edmonton, but never one so focused on death. So we're very interested to hear more about what you've done there. So we might reach out to you. So maybe I'll pose that question to the whole group. You can use the chat function. Is anyone hosting workshops at their PNs or at their clinics? And if you are, just maybe put the name of your PCN up, and then would that be something that we could potentially explore in the future? And then at the same time, use the function to more questions. Wrench, I'm ignoring you. We'll get to your question right away. You're the only one who's asked a question so far. So. Any workshops? All right, you're posting that. I think this question was posed to Laura. Laura Marencha Jeppe is asking, how are your clinic tracking offers for ASAP maneuvers? So you spoke about the use of screening in the HQCA report, and then I think she probably wanted you to expand on that.
So we do, a couple of years ago, we started doing an initial chart review, and then every year thereafter we do a sustained chart review, and that takes 20 random patients from each of our physicians, and we go through to find out how many of the ASAP maneuvers were offered to our patients. And there is a spreadsheet that you can obtain from your improvement advisor through TOP, and then you can submit the data to them, and they will provide you with a report. And so tracking the offers.
We have a question here from Stephanie Balco. Question from them. Stephanie's literally sitting right next to me. That's why I'm laughing. Her question is to the Mosaic folks, and she's wondering, are the docs encouraged to come with their clinic teams? How many of your participants were doctors versus other team members?
At that particular one, and I think moving forward, we did encourage them to bring their clinical team. So all of the participants walked except for a few came from other PCNs and TOP just to observe at this point.
Planning on hosting any more? Because we kind of want to do a field trip to Calgary to come sit in on it.
All right. So 4 more sessions in terms of content, and each session we're planning on offering each session twice, similar to last time, just to accommodate different schedules for physicians. And again, this is in planning phases right now, and will largely be related to evidence that we have around our evaluations for the program.
One last question from Stephanie again. Do you provide physician compensation?
Yes.
Yeah, always helps with the numbers, right? All right, so we have 2 minutes to go. Next slide, please. Thank you to our speakers today. It's really nice to see just kind of a little bit more insight into how everybody's using the HQCA report. So we'll take 30 seconds here and have everyone chat in what will be their next step in using HQCA report.
My doctor just set their own goals.
Oh. Okay. Getting physician approval to order reports, yeah. I know at our PCN we've actually worked on our IMA, or information management agreement, with our physicians so that we can order them for them. And so that definitely, that building that relationship, that trust will help. And making sure they actually get the reports and look at them, which would be good. That's fair. All right, next slide.
So it's Peter at Mosaic. Just to comment on the data sharing agreements, I would say that's probably one of the major factors or foundational steps for us to be able to do a lot of the work that we're doing. I'm not sure whether we have shared our data sharing agreements with others, but I think we'd be very happy to. We're created in conjunction with the AMA and OIPC, so we'd be happy to share that.
Peter, yeah, if you can kind of send that along to your top improvement advisor, who I think is Carrie down there, and then we can make sure that we put that on the Collaborate page. Thanks so much. Next slide, we'll just wrap up here. I think we only have like 30 seconds left. So our next call will be April 5th, same time, same place, 2 to 3 p.m. We'll be to kind of a deeper dive into paneling and screening as basically a Schedule B indicator. So Lori and Carrie from kind of the South Calgary zone are gonna talk about that. And then next slide, please. You'll also receiving a survey in the next few minutes here. We're trying to collect more information on what you would find valuable as improved facilitators in the province. So that will be in your inbox here in the next few minutes. So please, please, please fill it out. It helps us out a ton. Please. And I mentioned quite a few times tonight, the Collaborate page. If you haven't gotten access to the Collaborate page yet, you can email info@pcmpmo.ca, and they'll set you up with a login and password. We asked about the date. Can somebody confirm the date? Oh, not the 5th. The next webinar will actually be the 9th of April, not the 5th. The 5th is a Thursday, so sorry about that.
That was my bad. I apologize for that. I did not catch that, so sorry about that. It
was 5th in February and in March, and so it's just an easy oversight. Thank you so much to all our guest speakers today and to everyone who tuned in, and we'll see you again in a month.